the channel The Cardiovascular Guru. I am Dr. Akshay Sharma and I am a cardiothoracic surgeon. The aim of this channel is to simplify the basics and the core concepts of cardiovascular medicine so that you can build your knowledge over it and gain clinical confidence. So let's get started. Today we'll go through the most commonly occurring arrhythmia, the atrial fibrillation. What we will focus upon? We will focus upon the basics, that is the risk factors, staging and clinical manifestations. We will see how it is diagnosed, especially with the help of an ECG. We will see how it is managed. The management part will be more of a working guideline rather than theory, and we will also go through certain real-time videos. References are standard Harrison textbook of internal medicine 21st edition and 2023 ACC American College of Cardiology and American Heart Association guideline for diagnosis and management of atrial fibrillation. So what is atrial fibrillation? These two words are very important, rapid and irregular. So rapid and irregular electrical atrial activation is atrial fibrillation. This is the cross section of the heart. Here's the SA node. The SA node fires. The signal is sent through the atria to the AV node, and there is an organized contraction of the atria. When this contraction is erratic, it is irregular, then it causes atrial fibrillation. So what are the consequences of this erratic and irregular electrical activation? First, mechanical complications and electrical complications. Mechanical complications are loss of organized atrial mechanical contraction. Atria contributes to 20% of the cardiac output. So when it is irregularly beating, then there is a loss of organized atrial mechanical contraction. This is the mechanical part. What is the electrical part? Now, the conduction across the AV node determines the ventricular rate. So this was about the atria. So how are the ventricles beating when the atria are contracting irregularly? The rate, how they beat, is determined by the conduction across the AV node. The conduction is variable. This is also another hallmark, and it is irregular. The rate can be very high, can be between 110 to 160. This is a typical rate of AF, that is the atrial fibrillation, but it can also be slow. So the important thing is the contraction is irregularly irregular. Atrial fibrillation is a arrhythmia that presents with irregularly irregular contractions. Now the AF is the most commonly occurring sustained arrhythmia, slightly more in men in comparison to women, and it significantly, mind the word, significantly increases the risk of stroke. So what are the risk factors? Increasing age. 95% of the patients which come to our outdoors or are inpatients who have atrial fibrillation are greater than 60 years of age. Underlying cardiac disease, practically any cardiac ailment, any cardiac pathology, whether it be TCMP, whether it be ischemic heart disease, can actually cause atrial fibrillation. Hypertension, obesity, diabetes, and family history of atrial fibrillation and sleep disordered breathing. These are important causes, risk factors of atrial fibrillation. What are the precipitating factors? These are the risk factors. What are the precipitating factors? Hypothyroidism, acute alcohol intoxication, myocardial infarction, pulmonary embolism, pericarditis, and post-cardiotomy. Post-cardiotomy means post-cardiac surgery. The heart is handled, so it causes arrhythmia, and in those settings the most commonly causing arrhythmia is again atrial fibrillation. Now the staging of AF. The staging of AF, that is staging of atrial fibrillation, is not that important, but the most important part is stage 3rd, and out of this the most important is to learn and understand this nomenclature. What is paroxysmal AF? Paroxysmal AF is intermittent AF that terminates in less than or in 7 days. In or less than 7 days, if the AF terminates, then it is known as paroxysmal AF. If it persists beyond 7 days, then it is what we call persistent atrial fibrillation. And if it is continuous and sustains beyond 12 months, beyond an year, then it is called as long-standing atrial fibrillation. Now we come to clinical manifestations. There are two types of manifestation. One are functional, the other which cause hemodynamic issues, that is the hemodynamic manifestations. Functional is caused by irregular and a rapid ventricular rate. This causes palpitation. Sudden onset AF, patient complains, comes to the ER or the outpatient department, says the patient that I am having palpitations. So what does AF cause mechanically? There is loss of contribution. As I told you before, atria contributes to 20% of the cardiac output. This loss of this cardiac output, variable stroke volume. The stroke volume with every beat is not constant. The beat, that is a sinus beat, gives a better cardiac output. So there is a variable cardiac output, and this ultimately causes exercise intolerance. So the two most common manifestation of atrial fibrillation is palpitations and exercise intolerance. Now the loss of atrial mechanical contraction, what other thing it causes? It can cause stroke because the atria are not contracting regularly, the blood is stagnant, there is blood stasis, and it is a cause of in situ thrombus formation, especially in the left atrial appendage. Now there is a thrombus in the left atrial appendage, then the thrombus can migrate, embolize into, if it goes into the brain, it causes stroke. It can also cause systemic emboli, especially in the limbs, causing peripheral vascular ischemia, or it can go to the renal arteries, it can go to the mesenteric arteries. Practically it can go anywhere. The most commonly what we find in our clinical practice is stroke and peripheral ischemia. Now let's see how to diagnose, especially with the help of a electrocardiogram, ECG. The hallmarks of the ECG in a atrial fibrillation patient. We will stick to the basics. We will not go deeper into the ECG concepts. We will not go into the combined lesions. We will stick to the basics and isolated atrial fibrillation patients. The rhythm is irregularly irregular, vary with variable ventricular response. No P waves. P waves are absent in the patients with atrial fibrillation. The ECG of atrial fibrillation, P waves are absent. There can be fine waves, these are known as fibrillatory waves. All of this with a background of a narrow QRS, less than 120 milliseconds, unless there is some other ventricular conduction abnormalities like pre-existing bundle branch block or SSC pathways. So if there are no ventricular conduction abnormalities, a narrow QRS complex with less than 120 milliseconds, no P waves, and a irregularly irregular rhythm is a hallmark of atrial fibrillation. This is a real ECG. We can see irregular rhythm. This RR interval is different from this. This is different from this. This is different from this. No P waves. You can see there should have been a P wave here. There should have been a P wave here. There are no P waves. P wave here. There are no P waves. The other QRS complex is narrow, less than 120 milliseconds. So irregular rhythm, no P waves, narrow QRS. This is how we identify the ECG of atrial fibrillation. So this is a real-time video. This is video of one of my patients who underwent a mitral valve replacement. This video shows a monitor of atrial fibrillation with fast ventricular rate. We usually call it AF with FVR. See, you can see irregular rate, RR interval are different. You can also correlate with the cardiac output. This is arterial line trace. Some cardiac outputs are great, some are very low, and blood pressure is on a very lower side. So this is AF with FVR, AF with fast ventricular rate. Now this is AF with controlled ventricular rate. The rate is 85, 86, less than 90. AF you can identify no P waves, irregular rhythm, RR interval are different, and better cardiac output. Arterial traces are good. You can see here also blood pressure is decent. So this is how you identify AF on the monitor. This is an operative photograph. How does AF actually look like in a heart? See, my forceps is pointing towards, this is the right atrium, this is the ventricle. You can see how erratic it is contracting. You can see it again. So now we come down to the management. Management will go through the latest 2023 ACC-AHA guidelines. First and the foremost thing, acute onset atrial fibrillation with significant hemodynamic compromise. The catch is significant hemodynamic compromise. The management is emergent cardioversion. There is no other way to manage these patients. The only reliable way to manage these patients, that is the patients with acute onset and significant hemodynamic compromise, is emergent cardioversion. Now this cardioversion can be done electrically or pharmacologically. Electrical cardioversion is done by QRS synchronized shock. The answer is not only shock, it is QRS synchronized shock. Pharmacologically, cardioversion can be done with class 3 antiarrhythmic, the ibutilide. So ibutilide for pharmacological cardioversion and QRS synchronized shock for electrical cardioversion. One thing is important, we have to avoid ibutilide in patients with prolonged QRS and poor LV function. Now the management of hemodynamically stable patients. We have three things to do. One, we have to control the rate. As we saw earlier, irregular fast rate is a hallmark of AF. We have to control the rhythm. We have to get back the sinus rhythm. And as we saw, stroke is a important manifestation, an important complication of AF. We have to mitigate the thromboembolic risk. So let's start by how we can mitigate the thromboembolic risk and ultimately avoid a stroke. First thing, can we identify patients who have increased risk of thromboembolism? The answer is yes. We have certain scores like Chad's VAS score, the Atria score, and the Garfield AF score, which tell us which patients are at more risk of getting a stroke if they get AF. The most commonly used score is the Chad's VAS score. We will see what are the components of this score. So these are the risk factors, couple of risk factors, and the score. The score is written in front of them. Congestive heart failure, hypertension, age greater than 75, age between 65 and 74, diabetes, previous stroke or TIA, and vascular disease. The score is given in front of them. If the score is 1 or greater than 1 in men and 2 and greater than 2 in women, then it is said that these patients have an increased risk of thromboembolism. So something to mitigate this risk has to be done. Some sort of pharmacological intervention needs to be done in these patients who have a CHAD-VAS score of 1 in men and 2 if the patient is a female. So how do we mitigate? Simply, to reduce the thromboembolic risk, we have to start anticoagulation. So anticoagulation, we have to start anticoagulants. We have two types of anticoagulants. One is vitamin K antagonist, popularly two medicines. warfarin and acetrom, and direct oral anticoagulants apixaban, rivaroxaban and dabigatran. Now the question arises, which drug in which type of patient? The things were complex in the previous guidelines when we used to distinguish between two type of patients, valvular and non-valvular patients. This is what used to happen in the previous guideline, but the latest guideline say the things are oversimplified rather in a better manner. Vitamin K antagonist in patients which have moderate to severe rheumatic mitral stenosis, or they already have a mechanical heart valve implanted in them. So these two subset of patients, moderate to severe rheumatic MS and with the patients with mechanical heart valve, to mitigate the risk of thromboembolism AF patients, we have to give vitamin K antagonists. Rest all, until unless it is contraindicated, give DOACs, direct oral anticoagulants, apixaban, rivaroxaban or dabigatran in them. Simple. Rheumatic MS, mechanical heart valve, give vitamin K antagonist, warfarin, acetrom. Rest all until it is contraindicated, like in severe renal dysfunction, give direct oral anticoagulants. To add to this, there is no role of aspirin in stroke prevention in AF. There is no logic, no role of adding aspirin for these patients. So how do we monitor? We cannot indiscriminately give anticoagulants to these patients just to mitigate the risk of thromboembolism, but ultimately we can give a risk of bleeding to these patients. So how do we monitor? Vitamin K antagonists are monitored by regularly doing the prothrombin time and the INR, and we have to titrate the dose of our medicines to keep the INR between 2.0 to 3.0. For direct oral anticoagulants, no monitoring is required. For the safety purpose, direct oral anticoagulants have a better safety profile, but we cannot give these drugs in patients with rheumatic MS or in patients who already have a mechanical heart valve. So, and one more thing, when giving DOACs, be cautious about the drug interactions and renal dysfunction. We have to be careful in patients already having the drugs which are either cytochrome P450 inhibitors or inducers. Now, we have covered one part. The other part is rate control. How to control the rate and why we should control the rate. We should control the rate for two important reasons. First, control symptom. The patient becomes very stressful, is in real distress when the patient comes to the ER that I am having palpitations. The other, tachycardia induced LV dysfunction. We have to decrease the risk of LV dysfunction due to AF as well. So rate control needs to be done for two things. One, control of symptoms. The other, prevent the risk of developing LV dysfunction. So what is the rate control? What should be the target? The target should be to control this is a lenient target between 100 to 110. A more stricter target would be to control the rate so that the heart rate comes below 90 beats per minute. So how do we control? Same story. Rate control in a hemodynamically unstable. Whenever the scenario is hemodynamic instability, the answer is cardioversion. We have seen how to what sort of cardioversion we can do. We have to, if we opt for electrical cardioversion, then it is a QRS synchronized shock. If we opt for pharmacological cardioversion, then it is abutolide. For hemodynamically stable patients, beta blocker or non-dihydropyridine, calcium channel blockers, verapamil and diltiazem. Digoxin can be given alone or in combination. Previously, we used to use digoxin very frequently in patients with AF, but now it is said they should be given alone only when beta blockers or CCBs are ineffective or contraindicated, or they should be given in combination to these drugs. Other thing, Calcium channel blockers, verapamil and diltiazem should be given in patients with EF greater than 40 and should be avoided in those who have LV dysfunction EF less than 40. Metoprolol tartrate for IV drug, IV route of administration, acute rate control. We can use short-acting beta blockers, esmolol, or non-selective beta blockers like propranolol. This is important, tartrate, not succinate. Metoprolol comes in metoprolol tartrate and succinate. So metoprolol tartrate is drug of choice here to be given IV. IV we can give esmolol and propranolol. For long term, this is for acute rate control. For long term maintenance rate control, the drugs are same: beta blockers, oral beta blockers, oral diltiazem and verapamil. Same story. Diltiazem, verapamil have to be avoided, and actually they can actually cause harm in patients whose EF is less than 40%. So LV dysfunction, avoid CCBs. Now what about amiodarone? How is amiodarone placed? IV amiodarone may be considered in critically ill decompensated heart failure patients in whom beta blocker and CCBs are ineffective or contraindicated. A patient comes to ER, you give beta blocker or a CCB for rate control and that is ineffective, then switch over to IV amiodarone. A patient comes to an ER, the patient has severe COPD, patient has severe LV dysfunction, he is decompensated, you cannot give beta blockers nor you can give CCBs, go for IV amiodarone. Now we have seen two management issues. One, we have seen mitigating thromboembolic risk, we have covered that, how to manage it. Then we saw rate control, we saw how to manage it. Now we come to rhythm control, how to revert these patients back to sinus rhythm. Same story, hemodynamic unstable. Whenever the word hemodynamic unstable comes in any arrhythmia, especially AF, go for cardioversion. QRS, I will again reinforce, electrical cardioversion, QRS synchronized shock. Pharmacological cardioversion, ebutilide. Avoid ebutilide. I'll repeat and 10 times I'll repeat. Avoid ebutilide in patients who have low ejection fraction, who have a poor LV function. The only drawback of shock is that it requires anesthesia and sedation. For hemodynamically stable patients, both electrical and pharmacological methods are acceptable. So if we opt for either of the cardioversion, what thing we have to keep in mind? Cardioversion in itself is a risk for thromboembolism. So if the duration of AF is less than 48 hours, straight away go for cardioversion. There is no doubt. If the duration of AF is or more than 48 hours, then do not go for cardioversion unless either the patient is anticoagulated for 3 weeks or you have confirmed or reconfirmed with help of imaging, transthoracic echo or transesophageal echo, that there is no intracardiac thrombus. If there is an intracardiac thrombus, then you should not cardiovert. That thrombus can dislodge from the heart and cause systemic embolus or a stroke. So if a patient comes to you with atrial fibrillation more than 48 hours, first anticoagulate for 3 weeks. Anticoagulation, we have seen acetylcholine, warfarin or direct oral anticoagulants, and then cardiovert. Or if you want to immediately cardiovert, then you have to rule out by doing imaging any sort of intracardiac thrombus. The imaging is TTE, transthoracic or transesophageal echo, and continue anticoagulation for next 4 weeks. This is how we do cardioversion in patients whose AF has been more than 48 hours. So QRS synchronized cardioversion we have already seen, and 100 to 200 joule of energy is given. So pharmacological rhythm control, if the LV function is normal, then we can go in for amiodarone or ebutilide. If the LV function is compromised less than 40%, we go for IV amiodarone. As we have seen, ebutilide should not be administered in patients who have poor LV function. and we can also use pill in the pocket, that is flecainide and propafenone, in patients who have AF outside the hospital and with normal AF. This is what we call pill in the pocket, flecainide and propafenone. So lastly, what happens if antiarrhythmic drugs are ineffective, they are not tolerated, or they are not preferred? In these patients, the treatment of choice is for rhythm control is AF catheter ablation. We will not go into the detail of catheter ablation, but this is a modality for those patients in which we do not want, or they are not suitable for antiarrhythmic drugs. So this was a quick summary, basic of atrial fibrillation. We had covered the basic concepts, clinical features, causes, risk factors. We have seen how a simple AF, not a complex AF, can be diagnosed with the help of an ECG, and then we gathered some working knowledge on the management of atrial fibrillation patients, both acute management and long-term management. So guys, we'll meet in our next video and learn a new concept in cardiovascular medicine. Till then, stay focused and study hard.